start with today, we have an additional 564 new cases of COVID-19 reported in the province, including 12 epidemiologically linked cases, bringing the total number of people in British Columbia with COVID-19 to 82,473. Of those, 168 are in the people in the Vancouver Coastal Health Region, 279 people are in the Fraser Health Region, 35 people are on Vancouver Island Health, 36 people live in the Interior Health Region, and 46 people live in the Northern Health Region. We now have 4,743 active cases across British Columbia, of whom 248 are in hospital, 63 in critical care or ICU. And we have 8,659 under active public health monitoring. And on the positive side, 76,289 people are now recovered. We've had 4 additional deaths in the last day from COVID-19, bringing our total to 1,376 people in our province who have succumbed to the virus. And our condolences go out to our families, care providers, and our communities who have lost loved ones during this most difficult time. We have no new outbreaks to report today, and we have 7 outbreaks in long-term care and assisted living, 3 now in independent living, with very small numbers, thankfully, on those, and 8 outbreaks in acute care settings. We have those involve the long-term care and assisted living involve 269 residents and 131 staff. Oops. I'm missing one of my notes around, there we go. As you know, we are following quite closely the variants of concern that are rising in the province and across Canada. And we've had an increase today of 46 new confirmed COVID-19 cases that are variants of concern. So that brings the total to 246 that we know about in the province. Of these, 16 cases are still active, and the remaining are people who have had past cases. 218 are the B117, which is associated initially with the UK, and 28 are the B1351, which is initially associated with South Africa. The majority of these variants of concern continue to be in the Fraser Health and Vancouver Coastal regions, 178 people in the Fraser Health region and 60 in the Vancouver Coastal Health region. There continue to be just the same small numbers, 6 on Island Health and 2 people in Interior Health, and no confirmed variant cases yet in Northern Health. As you know, we are most concerned as well about transmissibility and where people are becoming infected with variants of concern. And right now we continue to have challenges in identifying the transmission chains for about 25% of our cases. There are currently 4 people in hospital, and 2 of the deaths that we've had in recent days have been people who had been infected with a variant of concern. As you know as well, since the start of our immunization program, we've had, we're almost at 300,000. We're 298,851 doses of vaccine have been administered across BC, and the number of second doses is about 86,746. And as you know, we made the very important decision, as more data was becoming available earlier this week, to increase the interval between the first and second dose so that we can maximize that really good protection that we're coming to understand that we would get from the initial dose of vaccines in BC. And I do want to acknowledge that this decision-making that we made, particularly around the extending of this interval, as we've had in a number of cases, reflects us learning as we go through this pandemic. We've learned about how the virus transmits. We learned about how are the measures that, where it's most likely to transmit, the measures that we need to take to protect each other from transmission. And as these vaccines have become available, almost day by day, but definitely by week by week, we are learning more about how they work, about their effectiveness, about their safety, which is also critically important. And the decision making that we don't take lightly. We spent quite a lot of time looking at it, but we did need to take this decision rather rapidly over this weekend after extensive consultation, because we were coming up to a time this week where there was tens of thousands of doses of vaccine being scheduled for people to receive their second dose, and that would have left us with very little vaccine to be able to continue our need to protect more people in more communities around the province. So while I will regret and apologize to those communities, to the long-term care homes, and to individuals who had a second dose scheduled that had been postponed or for several months now. And I know that came as a shock for many people. And I regret that our communications weren't able to keep up as fast as the decision making. But please know that this was made in the spirit of understanding data and maximizing the benefit to all of us. And that dose you didn't receive on Tuesday or Wednesday or today is now being administered to a community member, to another member of our family, our community here in BC, to protect them. And ultimately, it will bring us all closer to getting to our post-pandemic world. Also want to address the fact that the National Advisory Committee on Immunization has also endorsed that this is the right thing for us to do in Canada right now. And I want to express my gratitude to NACI. NACI is an amazing group of experts. I've had the privilege of sitting on the National Advisory Committee for 8 years. Some of our colleagues here in BC, our best brains around immunization, have also been both members and chairs of NACI, and we tremendously respect the work that they do, and we're just very grateful that we have all come up with the same important decisions around these critical issues for us in BC and in Canada. As you will also know, the first deliveries of the AstraZeneca Serum Institute of India COVID-19 vaccines will be arriving in our province, we expect sometime next week. This vaccine will be made available to first responders and other essential workers, and the delivery of these vaccines will run in parallel, but separately from our age-based community-wide immunization program. And when I say that, we had in our initial plans, it was looking at phase 3 and 4, because that's what we understood these vaccines would be available. So it is an added bonus to us that we now have these vaccines earlier in this program. But I also recognize that the category we're talking about, first responders, essential workers, is a very broad group of people. And we have come to recognize through this pandemic how many people absolutely are essential workers, or people who cannot work from home. And we know that that covers a broad swath of people. So as we have done with our immunization so far, we will prioritize our delivery of these vaccines accordingly. And I want to be clear, this is not a random process. This is not me making a decision out of the blue. We follow a very defined process. And I referred initially to NACI, the National Advisory Committee on Immunization. Earlier on, when this pandemic started, we all went through a process of determining who vaccines could be available to, who would be the priority populations if and when vaccine became available. And those lists, those categories have been refined and revised over the period of the last 10 months. And since we've had vaccines available, they've been revised again. Early on, we didn't know if vaccines would be effective in older people, as many other vaccines are less effective. But we now know that they do work, and they work very well in older people. They work well in people with chronic illnesses. They work well in many populations. So that's allowed us to monitor and change things a little bit in terms of that. And here in BC, we have a long-standing BC Immunization Committee that is also made up of experts from public health, from vaccinology, the Vaccine Evaluation Centre. We have pharmacists and family doctors and infectious disease specialists and others who have sat on this committee for many years. It rotates periodically, and it's supported by the BC Centre for Disease Control. And so our recommendations around who gets vaccine when are based on using the NACI guidance, looking at the data in the real world, and the analysis that's done by our standing committee, the BC Immunization Committee, which is our provincial level equivalent. And this committee uses public health, both the immunology, vaccinology, vaccine science, and public health principles, as well as an ethical framework. And I would refer people to the BC CDC website, where we have our ethical framework for decision making around vaccines as well posted. So based on this information, we will the BC Immunization Committee is right now going through a process of defining who should receive vaccine when, as it becomes available, and that we will ensure that those groups are then sequenced and we put the operational pieces into place. So those recommendations I expect are coming to me in the coming days, and based on this information, a detailed plan will be developed over the next week to 2 weeks, which we will share publicly as soon as we have those details ready, and I'm hoping and expecting that will be around the 18th of March. In the meantime, we are planning to use the initial shipment of the AstraZeneca vaccines, the Serum Institute of India vaccines that are coming available as soon as we can, to address our ongoing clusters in outbreaks that are leading to some of these rapidly increasing numbers in some places, some communities, to best protect our communities. So we know that there are some outbreaks right now that have been going on that have been challenging to manage, where immunization is going to be that extra tool to help us manage those, so that we can stop that cycle of workplace to community transmission. And that will be our focus initially. So also today, I wanted to bring us up to date on something that we've also talked about quite a few times over the last number of months, and that's our strategy and our plan for use of point-of-care testing. So part of our response, we are using these rapid tests as another tool to support public health contact tracing and outbreak response efforts. And we have a strategy that has developed and evolving since we started to receive these tests early November of 2020. So there's a couple of things that we need to sort out. When we talk about rapid testing and point-of-care testing, we do have some PCR. So PCR is the lab-based testing. It's our gold standard. It's the one that we use for a diagnostic test for COVID-19. It's high sensitivity, so it's the most accurate of the tests that we have. And we do have some machines that are able to be used in smaller settings that are outside of a laboratory. So they're called Gene Expert or BioFire machines. And we received some of those earlier on. We had a few here in BC already that we repurposed to be able to put in smaller communities. And the whole purpose of that was try to reduce the turnaround time from when somebody got a test to when they got the results. And we report on turnaround times. And for PCR testing, the turnaround time now is less than 24 hours in most places. But in some communities, the travel time to get even to one of these point-of-care PCR tests can mean that there's a delay of a day or two. And this is where rapid testing can come in to fill a gap. So when we're talking about these rapid tests, the point-of-care rapid tests, we're talking about two types of tests that have come into BC. One of them we call a RAT, which is the rapid antigen test. So it looks for the antigen in the swab, and it's what we call it a laminar flow test. So that's the little ticket test. Right now, those still require either a nasal pharyngeal or a nasal swab. So you have to stick the swab up your nose. It can't yet be used with the swish and gargle and spit test. Those ones we use in places where you can do multiple people at a time. The other one that we've had in Canada that we started to receive in November was nucleic acid amplification tests, so RNATs. And these ones are more sensitive. They're a little bit more accurate, but they also require a nasal pharyngeal swab. Initially, nasal pharyngeal swab. Very recently, we've got anterior nasal swabs. Those were only approved for use a few weeks ago. But these ones require a machine. It's a small portable machine, and it can only do one test at a time, and that's important to remember as well. All of these tests take about 15 to 20 minutes. So in October last year, when Government of Canada began to approve these point-of-care testings, we started to receive them at the end of October and into November. It's important to recognize, though, that there is a step that needs to be taken when these are shipped out to validate each lot of tests. And we do this for many things. It's a quality assurance process to make sure they work as they're supposed to. And that validation process could not be done in the scale that it needed to be done by the federal government. So we were required to do that here in BC. So we did that as rapidly as possible through the BC CDC, the St. Paul's Laboratory, and those tests were validated mostly in November and into December. Since that time, we've done 39 pilot projects across BC about where these tests can be used to try and determine where their best use is. We've used them in settings from long-term care facilities, rural and remote settings, so times when that turnaround time to get the more accurate test takes too long in our provincial correctional facilities. We've used them in a number of different situations to manage or to assess outbreaks in workplaces where we've had a number of workers who are positive. It allows us to rapidly assess the scope of how many people might be affected and to supplement it with PCR testing. We've been using it as well to help us understand whether there's been transmission from the variants of concern in school settings. So we did that, and the first time we used it was in Garibaldi High School, where all of the cohort who were infected, we used both the point-of-care testing, the rapid test, to understand anybody who might be infected at that time, but we also had to use the PCR test so that we could understand the accuracy of the rapid test. So we've also used it several times in schools when it will change management. And this is the principles that we are using these tests. They supplement the other measures that are in place, and they help us to understand when we need to do things rapidly. And there's two situations that we use them. One is when for testing of people with symptoms to determine whether they might have COVID or something else. This has been very helpful in situations where people have had a test 3 days before and they go for surgery, and the day of their surgery they have a bit of a cough or a bit of a runny nose. So a rapid test in that situation can help us know whether it's safe to continue with that surgery, and those are some of the situations we've been using here. We use it for testing of people in the downtown east side, for example, people in congregate living settings, when it's hard to tell if the symptoms they're experiencing are from COVID or from withdrawal symptoms. So they have been quite effective in those situations. The second place that we are using point of care or rapid tests are in people who do not have symptoms. And it is in that situation that it is more challenging to understand where the role of these tests is. We have been using it in a number of long-term care homes to screen healthcare workers when they come into work who don't have symptoms, to see if they may have COVID-19, asymptomatic shedding. And we've done that in 7 different long-term care homes so far. Of the thousands of tests that have been done, 2 of them have been positive. And both of those cases were in facilities that were having an outbreak. So what this tells us is that when the background level is higher, your probability of picking up somebody who has an asymptomatic infection that doesn't have any symptoms goes up. and that they're not as useful in areas where the background levels are low. So if our community transmission rates are low, screening with these less sensitive tests is not very effective. It doesn't help us because the yield is so low, and they have a much higher false negative rate. In those areas where we have an outbreak or where community transmission rates are higher, that is when they might have more utility, and those are the areas that we're looking at more closely. So we really want to look at accessibility. It's helpful in areas where the gold standard PCR test is not as accessible, where we need to make a decision right now, so rapidity, where quicker results will change what we're going to do on a day-to-day basis or on a right now basis. And the advantage they have is they're relatively low cost, the tests themselves, but they do continue to need to be done within a healthcare environment. They are a medical test, and they do need to have a quality assurance program, and we need to connect with public health for every positive that needs to be validated, and to be assured that we can follow up on anybody who tests positives. So these are the situations that we've been using now. We use them where they fill a gap, as I said, and where compliance with public health measures are ensured. They do not take the place of all of the public health measures that we need to have in place. And we still have a lot of questions about places where they are best used. Is it better? A couple of things that we have learned from both the pilots here and across Canada is that acceptability of having a test goes down over time. It's not comfortable or nice to have a swab, particularly in people who don't have any symptoms, on a periodic basis. And so we know that in the long-term care homes, for example, worker testing could not be more than about twice a week. And is it better to use a point-of-care test twice a week or the more accurate PCR test once a week? And those are the questions that we're still wrestling with, both here in BC and in provinces across the country. There's still a lot that we need to learn, but we are establishing a rapid point-of-care testing team with our BC CDC lab and the ministry, and partnering with our health authority, public health leads, but also with different settings across the province to see where we might use these best. And as we move into this time when we have increased immunization of people and we're moving into our post-pandemic opening up, we're looking at where we're going to, where there's a benefit for different industries to have point-of-care testing or these rapid tests as part of the opening up process. So these are industries where outbreaks are more likely, like our food processing industries, like some of the agriculture, the large industrial sites. And we are partnering with industry right now to see how those can work in the coming weeks and months. Which is all to say, these are challenging. We're learning as we go with testing, as we have with all the other aspects of this pandemic. And we now have a written out strategy that will be published on the BC CDC website, and we'll have links to it aligned with our statement later today. So with all that, I will summarize by saying, we are in a new place right now in the COVID-19 pandemic. We're getting our regular supply of vaccines, and more vaccines are on the way. We know that the Johnson & Johnson vaccine is in for final review with Health Canada. We don't yet know when it might be available, but that will be another tool, another piece that we can add to our toolkit. We know that we have increasing protection in our most at-risk people, and that will increase dramatically starting again next week. But we've also had an uptick in new cases, and we've seen the rise of some of the more transmissible variants in our communities here, particularly in the Lower Mainland. And we need to follow those and monitor them carefully. We can't let these successes of these great vaccines that we have now be diminished by a surge in cases that will lead us to a third wave. We know that we are taking all of the public health actions of case management, contact tracing, isolation, testing, making sure that we are doing what we can to contain the transmission that we have right now. And that is going to be incredibly important. And I know these restrictions and closures in many parts of our society have been draining on all of us. And we all want to get back to our regular activities as soon as we can. We know that the transmissibility of this virus, or at least we've learned, that it has a seasonality to it. And here in BC, we're coming up to that season in April and in May. I'd like to assure everybody that we routinely, every day, but every week, review the measures that we are using to determine whether these restrictions are still needed, whether there are things that we can do now safely that we couldn't even a few weeks ago. And the work we do is ongoing. We have had a response that is a whole of province response, and everybody has been doing their part. And it's about using all of our tools through this next period of time until we have more people protected, until we have a handle on the transmission in our communities. And it is a whole new place that we are moving into very quickly. Brighter days are ahead. So let's continue to stay this course with our safety measures, staying small, staying local, so that we can get there even faster. And let's, of course, remember to continue to be kind and to be calm and to be safe.